Hi, this is Elliot Fishman, and welcome to our latest podcast. This is going to be on a very simple topic. I want to show you some nice examples of processes that involve the chest wall. Some are primary, arising in the chest wall, and some are secondary. So I'll show you what I mean. Let's go through some of them. Now, if you think about chest wall disorders in general, that you might see on CT, that could be congenital development anomalies. Well, maybe think of Poland syndrome with absence of the pectoralis muscle on one side. You can think about inflammatory or infectious diseases, abscesses, processes that extend from the mediastinum or chest wall into the soft tissues of the chest. And you can even think about soft tissue and bone tumors. Obviously, when you think about soft tissue, we think about different primary tumors, but we can see metastatic disease as well. And of course, in the chest wall, we have the breast, and particularly in females, complications such as breast cancer and involvement with nodes or spread or soft tissue masses are all things that we might see. Now, when you think about the chest, we can see it many different ways. I do like to use cinematic rendering, and I just show you this example where the patient has had a prior medial stenotomy. We were doing a vascular study. You can see the leads over the chest. You can see a little bit of the muscle on the image on the left. Image on the right is basically bone. Here I'm adding a bit more of the pectoralis major muscle. You can see really small nodes in the axillary region. And here's a little bit more change in the cinematic rendering. A little bit more muscle, a little bit soft tissue. So again, how we look at things will depend on whether we're looking at bone or soft tissue or muscle. Now, trauma is one of the things that can cause processes to involve the chest wall. You can think of fractures, be they sternum or be they ribs. You can think about injury to soft tissues like hematomas or air. You can see in this case the patient had chest tubes placed and there's extensive air around the pectoralis major and minor muscle as well as in the subcutaneous tissue. Now you can see air in the chest wall from the chest tubes being placed or from the initial trauma. Obviously, with trauma, you want to look very carefully. You want to look at the sternum and the ribs. And of course, you look at the aorta. Patients who have injury to the chest wall are more likely to have injury to vascular structures like the aorta. And in this case, there was a dissection near the level of the ductus region, very nicely shown. I think in terms of looking at the chest wall, axials and sagittal views are particularly the best view. And here's just another look at that aneurysm at the ductus region and a very subtle fracture in the patient's body of the sternum. And here's just a few more looks on the 3D imaging of that vascular injury. Another patient, here the chest wall injury is larger. Air in the soft tissues. You see the fracture of the body of the sternum. You see the disruption between the manubrium and the body. You also see the very active bleed in the aortic arch. There's a transection of the aorta with active bleeding. This patient, in fact, was lucky. Most patients with this kind of injury will die, will never make it to the CT table. This patient made it to the CT table, went to the OR directly, and actually did well. You can see this patient, not uncommonly when you have chest wall injury and you have significant trauma, you often can get thoracic spine fractures as well, as you can see in this example. So again, using soft tissue window, using lung window a little bit for looking at air, and looking at bone with bone windows is valuable in showing you the extent of the trauma and the extent of chest wall involvement. And again, here's that same patient with cinematic rendering. You see the active bleed, you see the sternal injury. Just a very nice example. And again, with cinematic rendering, looking at soft tissues or bone or muscle, it's a really good way to do it and can provide you with a lot of information. So a really nice trauma case with chest wall involvement. Here's another patient. This could be due to trauma. It could be due to biopsy. It could be due to anticoagulant therapy. This was due to a biopsy, but there's an active bleed in the patient's left chest wall within the breast, involving the pectoralis major muscle for the most part, with a fluid level. There's also stranding in front of the sternum. Again, bleeds can be due to many causes, and so when you're looking at chest wall or chest wall pain, think of that possibility. Look for active extravasation. I don't see that here, but you can see the high density and the fluid level consistent with blood. And on these 3D reconstructions, you can see right here, there's some active bleeding. So in many ways, the 3D may be helpful. You can also see the internal mammaries. And again, looking at the individual structures. And now you can see the active bleed a little bit better at the very lateral portion of the study. Sometimes the bleeds are best seen in arterial phase imaging, sometimes best on venous phase. Most of the time you'll see them in both phases. The one phase may be better than the other. Now this is an interesting case. It looks like high density material like calcifications. It looks like almost like bullet fragments or pellets, but that wasn't the case. You could think maybe the patient had breast reconstruction and had silicone injected. That's a possibility. But this patient was from Africa, and this is one of the diseases that the Gates Foundation is working very hard to get rid of. Those are all worms in the chest wall, and they're calcified in part. Look how impressive they are. It's an unusual diagnosis. Diffuse calcifications. It was a guinea worm. And again, I mentioned the Gates Foundation. One of the things they're trying to do is eliminate certain diseases, and guinea worms, which causes significant morbidity and mortality in the African population, is really very close to being eradicated. A lot of the work started initially with the Carter Center, so this is since 1986, the guinea worm eradication program, and the foundation from Gates is trying to make this really happen. So it's a parasite caused by the nematode roundworm parasite Dracunculus medianesis. I know I pronounced that incorrectly, but you can see the importance of getting rid of such a really high morbidity, high mortality patients. You can see in 86, the disease affected 3.5 million people in 21 countries, and now it's nearly wiped out. And in several countries, it is wiped out, and within 5 years, it will no longer exist. Now, other masses. Here's a large mass involving the body of the sternum. You can see it on the axial and the sagittal views. It's a soft tissue mass. It could be metastasis, could be a primary tumor. You can see other lesions in the thoracic spine. This was a good example of a plasmacytoma. Plasmacytomas are often mildly vascular, but very aggressive and destructive. Often involve multiple bones and soft tissue. And this is a nice example of a classic location in the sternum, really nicely shown in the body of the sternum on the sagittal views. Here's another case with a mass in the anterior mediastinum which connects to the mass that's in the chest wall, and there's a matrix present. Now this patient did not have radiation, did not have injection. So what are we dealing with? Well, you usually think about chondrosarcoma or osteosarcoma as two tumors which can involve the chest wall and have matrix. This was a really nice example of a chondrosarcoma that grew from a little nodule to the left of midline posteriorly and presented as a large retrosternal mass. This patient had extensive surgery and actually has done very well. But a really nice example of a chondrosarcoma. Again, looks a little bit similar to the plasma cell tumor I showed you with myeloma a few moments ago, but here there's matrix present. And with matrix, I'm thinking osteosarcoma or chondrosarcoma. Just a really nice example. So a really, really good case. Now, another patient with chest pain, there's infiltration of the anterior mediastinum, and it extends beyond the anterior mediastinum through the chest wall. Now, there are many different tumors in the anterior mediastinum. You think about teratoma, thymoma, thyroid, and lymphoma. The one that's most likely to be homogeneous and grow through because of usually internal mammary nodal involvement is going to be lymphoma. Look how this tumor really just infiltrates in the mediastinum, but also through the chest wall. There is some subtle bone involvement, and this was a really nice example of lymphoma. And in fact, it was a B-cell lymphoma, nicely shown here with IV contrast material. Now, you can get metastasis. I mentioned primary tumors like chondrosarcoma, plasmacytoma, but metastasis. Destructive lesions, melanoma, renal cell carcinoma are two things you might think about. We also see sarcomas involving the chest wall or beginning in the chest wall, then growing through. This was a sarcoma. You can see it involving the ribs, growing through the chest wall, pleural effusions, and a really large tumor mass infiltrating the lower portion of the patient's right lung. Just a really impressive case with extensive tumor in the soft tissues, in the lung, in the mediastinum, tracking down into the abdomen proper. And you can see how extensive this tumor is. So tumors that grow upward from the abdomen can involve the IVC, can involve the chest wall. Sometimes you can figure out there's a large mass, but it may be harder to predict what it is. I mentioned breast cancer in the overview. Here's a complex cystic and solid breast cancer. There's some early involvement of the pectoralis major muscle. And breast cancer, obviously, we don't do CT routinely, but the patient's presentation may be on a CT scan. It may be simply chest pain, and no one thinks about breast cancer. But this is a really nice example, and you can see that there's a feeding vessel. Breast cancer on CT is often vascular. In the beginning of CT, people thought that maybe CT was good for distinguishing benign versus malignant breast lesions, with the malignant lesions being vascular and the benign lesions not being as vascular. And here's the MIP imaging very nicely showing you the mass in the patient's right chest wall with involvement from breast cancer. Now, other things, you can get collaterals in the chest wall. If you have SVC occlusion for benign or malignant reasons, you can see collaterals through the internal mammaries, into the chest wall, through intercostals. Just a very nice example of chest wall involvement by collaterals, and you can see that there's a catheter in the SVC, and the SVC is nearly occluded. So I've gone through a number of things showing you the chest wall can be involved in a range of pathologies. It may be the primary site of disease, or it may be the secondary site with direct extension from a mediastinal process, a distant metastasis, or local infection. And again, there's overlap. It's not always going to be possible to be specific, but I think you can make the diagnosis, suggest what needs to be done next, biopsy, and be fairly accurate on what the primary disease process is going to be. And with that, I'll stop there. I think I'll go get a drink of water, and I wish everybody a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.